It's now my pleasure to announce Professor Khay Guan Yeoh from the National University in Singapore to give us a presentation. Professor Yeoh is the Chief Executive of the National University Health System and Professor of Gastroenterology at the National University Hospital at the NUS. And while being a practicing gastroenterologist, he is also a highly active researcher with more than 200 papers and also leading the National Singapore Gastric Cancer Consortium. Professor Yeoh, thank you. Stage is yours.
Thank you, Markus. Good afternoon, everyone. Like everyone, I think I'm really enjoying this meeting. I want to thank Robert and Gerhard for organizing this wonderful meeting. It's really special to be in a room where everyone's really passionate and interested about gastric cancer. Must be one of the best gastric cancer meetings in the world. Today I would like to accomplish two things. One, to share our approach on gastric cancer prevention from the Singapore perspective, and then to add on some recent data on intestinal metaplasia and genetic alterations, because we think that it points to the origins of gastric cancer for a certain subgroup. So for those of you who haven't visited us in Singapore, I hope to welcome you one day. I'll be talking about the primary and secondary prevention, and since this is a biomarker session, a microRNA serum biomarker for gastric cancer and how we plan to use it. Then some thoughts on intestinal metaplasia and its genomic and genetic alterations. This global heat map has been shown many times this meeting. I'm just pointing out that in Singapore we are intermediate risk population with about ASR about 8 per 100,000. So much lower than in the East Asian countries, perhaps still a bit higher than it is in many populations in the Europe and in the US. So from that perspective, in terms of primary prevention, we do not have a systematic population screen and treat strategy, but we would do test and treat in the clinics. And in terms of secondary prevention, I think we could divide the thinking into high prevalence countries like Korea and Japan, where endoscopic screening has been adopted. While for low to intermediate risk populations, we feel that we should focus on screening just the high risk groups. So high risk can be determined by demographics. So for example, age above 50, certain populations at high risk, certain ethnicities, Helicobacter positivity. Or it could be determined from a serum biomarker. So on the left here, we feel that in our population, a blood biomarker could be used to identify high risk versus low risk populations, high risk going on to endoscopy. And when we do endoscopy, we'll find many alterations in the gastric mucosa, some of whom will need surveillance. And we're working on a test to identify people with very high risk so that we focus endoscopy on that very high risk group. So if you like, the blood test is a biomarker for screening in the population, and the molecular test is a test to identify very high risk patients. So the blood biomarker, we published this in Gut in, I think it was 2020. It's a serum microRNA biomarker panel. So just to bring us quickly through it, we screened 578 candidate microRNAs, and in a discovery phase, which consisted of about 472 patients with 236 being cancers, identified biomarkers that were differentially expressed in cancers, went on to verification phase, which was a Singaporean and Korean population. The Korean center was Yonsei Medical Center. And this then, in a case control design, produced a 12-member microRNA assay panel, which was then validated prospectively in the Singaporean cohort. So these were the results. The left shows the ROC curve. So the area under curve is 0.85. The sensitivity of the test was 0.87, and the specificity was 0.68. And on the right, you see various stages of gastric cancer. So you can see that even in stage 1 and stage 2 cancers, the test has quite a high sensitivity, 87.5 to 89.5%. And this correlated nicely with size of the tumor. But even in stage 1, it's reasonably sensitive. We went on to do studies on cost effectiveness, and so using this microRNA serum test for gastric cancer in a high-risk population, Chinese males aged above 50, predicted that it would be cost-effective. And this has received approvals in the European community, the CE mark in 2017. HSA is the Singapore Regulatory Authority, so we got approval in 2019. And last year, the FDA granted a breakthrough device designation. So this biomarker panel, I think, has the potential to be a screening tool for gastric cancer. This is an example of its use. It's been commercially available in Singapore for the last 2 years. So the case here is of a 47-year-old male with no complaint, but the GP did a gastro-clear test on this patient, which showed moderate risk. He was then referred to endoscopy, which showed ulcer at the gastroesophageal junction, and the biopsy showed adenocarcinoma. So an example of how it's been used. Next steps, where we think it's going, the current performance characteristics, sensitivity is quite high, 87%, but the specificity is lower at 68%. So if used it's not ready to be used in an average risk population because it would result in too many false positives. So we feel that this can be improved by adding DNA methylation markers, which confer a higher degree of specificity, and then that combination might result in a better performing test. So I'll go on quickly to intestinal metaplasia. This has been discussed extensively yesterday and today, so I'll skip a few slides. Start with the GSAP cohort study, which has been mentioned in a few earlier talks. So this was published in GUT in 2022. GSAP was a cohort, GSAP standing for Gastric Cancer Epidemiology Study, was a cohort of 3,000, and about half the subjects, 1,500, had intestinal metaplasia. Prospective study of endoscopic surveillance and follow-up over 5 to 7 years. And the follow-up over 5 years showed good relation between severity of metaplasia and the subsequent development of gastric cancer. So in a cohort of 3,000, if we divided them into subjects that did not develop gastric cancer versus those that developed early gastric neoplasia, these were the differentiating characteristics. So you can see that age, pepsinogen, atrophy, intestinal metaplasia had a risk ratio of 5.36, and higher OGIM stages, the risk hazards went up. So this graph, I think Robert nicely showed yesterday. The left graph shows that as the OGIM stage increases, the age-adjusted incidence for developing early gastric neoplasia increased dramatically. And on the right, compared with subjects with OGIM 2, the group with OGIM 3 to 4 developed early gastric neoplasia over shorter periods of time. So over a mean of 22.7 months compared to 50 months in the group with OGIM2, and this was highly significant. You could ask, what's the natural history of intestinal metaplasia? And in the alluvial diagram on the left, each line here, each single line here represents one subject with metaplasia, followed up over 5 years. So their start stage was year 0 and the end stage was year 5. So you can see that, for example, taking subjects with OGIM1, many of them regressed or their metaplasia reversed after Helicobacter eradication. Many remain the same, and some progress to higher grades of OGIM stage. If you look at the table, the first column shows the start stage, and the 4 columns on the right, the end stage. You can see that taking OGIM1, for example, very few of them progress to severe outcomes. Only 13% progress to higher stage. If you look at the OGIM3 and 4, you'll notice that none of them regress completely. None of them reverse their metaplasia. So we believe that OGIM3 and 4 represents the stage of a point of no return, because they don't reverse back to having no metaplasia even after you eradicate Helicobacter. And why is this the case? It's probably because there's extensive severe inflammation resulting in methylation and epigenomic alterations, chromatin damage. So you have substantial genetic alterations even at this stage of high-grade metaplasia, which in some cases will progress on to dysplasia and carcinoma. Yesterday I think we had a good session on surveillance guidelines, and here I show the difference in the European MAPS2 guidelines and the Singapore guidelines that was published 2 years ago. The main difference is that we agree that for advanced stage metaplasia or atrophic gastritis, we would do surveillance in 2 to 3 years. For OGIM2, we suggest endoscopic surveillance every 5 years. So the data, the tissue and cellular data from GSAP lent itself to genomic analysis. So we went on to perform genomic and single-cell RNA-seq analysis of intestinal metaplasia. In this first paper in Cancer Cell 2018, we looked at the genetic alterations that were associated with progression from metaplasia to carcinoma. And there were 3 significant ones: increased mutation frequency, shortening of the telomere length, and copy number changes. So these 3 associated with progression of metaplasia to adenocarcinoma. And our group went on to publish a single-cell atlas in gastric cancer. So this effort was led by Patrick Tan and published in Cancer Discovery. This looked at 31 patients with gastric cancer and more than 200,000 cells. The single-cell analysis reviewed 34 cell states with 5 major cell types, mainly dominated by the immune cells. So myeloid, lymphoid, and plasma cells dominated this. There were also, of course, epithelial cells and stromal cells. And we went on to extended genomic analysis of intestinal metaplasia. So this built on the earlier analysis. We expanded it to 1,200 biopsies from 690 subjects. And we performed a high-depth DNA-seq, RNA-seq, as well as single-cell sequencing for metaplasias from the stomach, antrum, and body. So these are the findings. 26 driver genes were identified in intestinal metaplasia. We just wanted to highlight SOX9. SOX9 is a transcription factor that regulates intestinal cell differentiation and stem cell characteristics. This was also, SOX9 was also found in the primary gastric cancers in the TCGA set. So we found that the higher expression of SOX9, the higher the stem cell signature. In the single cell analysis for intestinal metaplasia, it reviewed 4 major cell lineages. The gastric lineage, so gastric stem cells, isthmus cells, pit cells, intestinal lineages, intestinal stem cells, transit amplifying cells, enterocytes and goblet cells, immune cells, and stromal cells. If you take the intestinal metaplasia and sorted it out into by severity into severe versus mild or negative metaplasia, in severe metaplasia, there was enrichment of the intestinal cell types. And in these cells, the cells with highest level of oxidative phosphorylation and MYC expression were the intestinal stem cells, more primitive IM cells. And when we put this together with the single cell atlas of gastric cancer, so grouping the gastric cancer cells with the IM stem cells, the closest cells to early gastric cancer were in fact the intestinal type stem cells. So we went on to do digital spatial profiling. These were subjects where IM gastric cancer and normals were in the same tissue. And the analysis showed that if you looked at the intestinal metaplasia stem cells, they were very similar to the gastric cancer cells in terms of oxidative phosphorylation and MYC1, in contrast to the intestinal metaplasia enterocytes, which showed adipogenesis and fatty acid metabolism. Beyond these, the gastric cancer cells showed EMT and mTOR changes. So the closest cells to the gastric cancer cells were the intestinal metaplasia stem cells. And in this hierarchical clustering of the transcriptomic data, you see that the tumor cells, which here are in the blue bars, and the red, which are the IM stem cells, associate closest. And on the other side of the spectrum, you see the IM enterocytes, which were quite different. So we found that stem cell dominant IMs showed expression signatures closest to gastric cancer, and we think that the stem cells might be the cell of origin. So how does it go from intestinal stem cell origin to dysplasia and cancer? And here we looked at the clonal dynamics. So a clone is a population of cells that share the same similar genetic characteristics. You can see that going left to right. So if you look at a row in the antrum, for example, the size of the clones represented by the colored dots increases from normal to intestinal metaplasia to dysplasia. In the normal course of events, clones develop and some will reverse and die off. The clone sizes expand when they retain a reproducing advantage. So you can see that the subclone size increase from normal to IM and expand further into dysplasia. So you might ask, how relevant are these mutations in dysplasia? So we did an analysis of a group of patients where we had, in one specimen we had adenocarcinoma, dysplasia, and adjacent normal. These were cases from Seoul National University, Professor Chung Hyung-soo. And in this analysis, we showed that pairs of dysplasia and adenocarcinoma, most of them showed at least one shared mutation. So 23 out of 28 shared at least one mutation. And the dysplastic clone growth was associated with certain driver genes like APC and P53. The subclones were more persistent and likely to transmit genetic events, and some went on to become adenocarcinoma. I showed these clinical guidelines earlier, and it is adding molecular test results to the clinical data, improve the prediction model on predicting which subjects with metaplasia develop adenocarcinoma. So with the addition of the molecular information, the AUC improved to 0.94. So this is the background for clinical trial that we are conducting presently with participation from 6 centers, including Stanford, Tokyo, Taiwan, Hong Kong, and Korea. And this clinical trial aims to establish whether a molecular test is able to predict patients developing stomach cancer over a 4-year period. So the hypothesis is those with molecular test positivity develops more cancers than the molecular test negative group. So these are the clinical characteristics. About 500 patients have been recruited, and it's undergoing. So we'll know the full results in another 2 years. So I'll conclude here. Firstly, severity of intestinal metaplasia predicts the risk of gastric cancer. There's some controversy whether IM is precancerous or paracancerous, but recently I think there is increasing evidence that some types of IM is a true precursor for gastric cancer, particularly the intestinal type of gastric cancer. And intestinal stem cells are a putative cell of origin for this type of intestinal type gastric cancer. In terms of surveillance, it's recommended for advanced stage atrophic gastritis or intestinal metaplasia. And a prospective clinical trial is underway with the aim of evaluating whether a molecular test can identify prospectively a subgroup of patients with a very high risk of developing dysplasia or gastric cancer. I'd like to thank all our collaborators. As you can see, it's a big group supporting these studies. Thank you very much for your kind attention.